We request the audience to participate in the case presentation, in the discussion. We want you to ask questions and trouble the delegates. Okay, now let's call the next participant, Akash Srivatsav, presenting tuberculous arachnoiditis and syringomyelia.
Organ of the body, and sometimes it presents in a bluffing manner to the clinicians. I now present one such case, tuberculous arachnoiditis with syringomyelia, managed in our hospital. Mr. GCSR, a 47-year-old married man, shopkeeper in Guntur, came with the chief symptoms of weakness of both lower limbs for 6 months, weakness of both upper limbs for 3 months, tingling numbness and paresthesias of 2 months duration, and bladder dysfunction for 2 months duration. The patient was apparently alright 6 months before, and he developed weakness of both the lower limbs in the form of inability to get up from sitting and squatting positions, climbing upstairs, auto rickshaw and bus, which was associated with stiffness. He also reported weakness of both hands while performing fine finger movements. He reported tingling, numbness and paresthesias of both hands and feet for 3 months, which was associated with no subjective loss of sensations. Girdle sensation in the upper trunk just below the nipples was observed. He had autonomic disturbances like micturition disturbances and sexual dysfunctions. There is no history of speech and language disturbances, higher mental function disturbances, cranial nerve involvement, and weakness of proximal upper limb and distal lower limb musculature. There is no history suggestive of involvement of the cerebellum and meninges, raised intracranial tension, and gait disturbances. In the past, he was diagnosed to have TB meningitis 20 years ago and received antituberculous therapy for 2 years. He underwent lumbar laminectomy 20 years back. His general condition on examination was essentially normal. His vitals were within the range. His CNS examination, he is a right-handed dominant person with speech and language normal, higher mental functions and cranial nerves normal. On motor examination, he had normal bulk in all the 4 limbs associated with spasticity. The power in upper limbs was essentially normal except for a 90% hand grip. The power in lower limbs in the proximal group of muscles is decreased. Reflexes, the superficial reflexes are present, plantar are bilaterally equivocal, the deep tendon reflexes, biceps, triceps, supinator and knee are exaggerated, and the ankle jerks are absent. The sensory examination, cutaneous pain and temperature are intact, joint position, sense and vibration are absent in all the 4 limbs. There is loss of vibration up to T4 vertebral level. A provisional diagnosis of spastic quadriparesis with peripheral neuropathy was arrived at. The differential diagnosis of spinal tuberculosis and other causes of myelopathy were to be excluded. Investigations, the routine investigations were within the normal range except for a raised ESR of 40 millimeters in the first hour. The CSF analysis showed a raised total cell count, a raised protein count, Pandy's positive and PCR for the TB antigen positive. Imaging studies, the MRI of whole spine revealed the presence of a syrinx extending from C3 to D11. This picture shows the presence of patchy hyperopacities in the lower portion of the spinal cord, suggestive of arachnoiditis. Nerve conduction studies, there is decreased CMAP amplitudes, absent F waves, absent SNAPs, suggestive of axonal motor sensory polyradiculoneuropathy. A final diagnosis of type 3C syringomyelia extending from D3 to C3 to D11 with tuberculous arachnoiditis leading to polyradiculoneuropathy was arrived at. He is now being treated with rifampicin, isoniazid, pyrazinamide, ethambutol along with prednisolone and tolperisone and being supplemented with pyridoxine, calcium and potassium. The present outcome is the patient had significant improvement in his symptomatology over the past 1.5 months. Discussion. Tuberculosis remains one of the treatable but most troublesome disorders affecting the central nervous system. This is a pathophysiological depiction of how a meningitis can cause syringomyelia. The tuberculous bacilli causing inflammation of the spinal cord leading to an inflammatory process and a cicatrix which further leads to a formation of hydrosyringomyelia. The actual pathophysiology of the present condition can be depicted as follows. The tubercle bacilli causing arachnoiditis leads to the inflammatory process in the subarachnoid space and involvement of the nerve roots, leading to polyradiculopathy. A high index of suspicion and detailed evaluation revealed the presence of a coexisting medically treatable condition in the patient who also had syringomyelia, which however did not explain his symptomatology. Also, surgery is deferred in this patient. To conclude, tuberculous arachnoiditis resulting in syringomyelia is a rare and late complication. Our patient has recurrence of tuberculosis which produced the present clinical picture. In-depth knowledge of the pathophysiology and meticulous workup are the cornerstones in successful management of such cases. Thank you.
What's the level of neurologic deficit here? What's the level of neurologic deficit? What's the level of neurological deficit?
The neurological deficit is present at the level of nerve roots, sir, at different levels where the tuberculous has extended.
Okay, what is the level, like C5, C6, or what is the level? You tell according the cervical or lumbar, thoracic, like that.
Yeah, it is extended from T6 level, below T6 level, sir.
T6?
Yes, sir.
T6. Then the biceps and triceps, you said that exaggerated. Okay, what's the root value of biceps and triceps? Where do you place the lesion here? In the spinal cord, what level you are placing the lesion, clinically speaking? I'm not talking about anything else, clinically speaking. And then how do you explain the absence of pain and temperature in a case where you supposedly say that it is syringomyelia?
Actually speaking, sir, I assume there is extent of infection in the whole length of the spinal cord, sir, in the along the meninges. In a case of polyradiculopathy, multiple roots will be involved.
Clinically you speak. So you presented nicely, but you answered also nicely. Clinically speaking, where do you place the lesion? Is it in the brain?
No, sir. Along the length.
Brain?
No, sir.
Is it in cervical spine? Cervical column?
Yes, sir.
Or cervical part of the spinal cord? Or the thoracic? Where do you place it?
Along whole length of the spinal cord, sir.
Whole length. So where's the upper limit?
C5, sir.
C5. C5 is 6. Okay, temperature and pain are absent. So if this patient comes clinically, I would keep as subacute combined degeneration of spinal cord as one of the differential diagnoses. But I find it's not mentioned here. And suppose a diabetic comes, the patient is diabetic. I would say that, what could be the thing? First tell me about the subacute combined degeneration of spinal cord. Is it a case of that or not? Can you say that? Why is it not that? Clinically, let us not talk about all your MRI, syringomyelia. Just tell me, clinically speaking.
Clinically, syringomyelia is characterized by dissociated segmental sensory loss, sir, and associated with brachial amyotrophy, sir. Because clinically the pain and temperature sensations are intact, we cannot say that it is a case of syringomyelia, sir.
What are the causes of syringomyelia? Because in this patient is tuberculous arachnoiditis. Any other causes for syringomyelia?
Yes, sir. According to the Barnett et al. Classification, syringomyelia can be classified into 4 classes, sir. The class 1 is syringomyelia due to obstruction of the foramen magnum. The second class is due to obstruction of foramen magnum, other idiopathic developmental defects. The class 3 is due to other spinal anomalies like traumatic intramedullary spinal tumors and spinal arachnoiditis. And the 4 is a pure hydromyelia, sir.
What are the various tracts that are affected in syringomyelia? Various spinal.
Syringomyelia, a portion of the posterior column will be affected, sir, and the anterior columns will be affected. The motor roots.
What are the tracts in the spinal cord? 1, 2, 3, 4. Quick.
Spinothalamic tract, corticospinal tracts.
Which tracts are affected here? Which tracts are affected here? In this case, what tracts are affected? Can you say that? Tell me. Corticospinal cord, then
spinothalamic tracts.
Can you tell the course of spinothalamic tracts?
Right then.
Thank you, sir, and happy Teachers' Day to you all.
Announcement for all of you. In the afternoon after the lunch period, we'll have the quiz in the auditorium from 3:30, so assemble there by that time. Afternoon session is the quiz after dumb charades in the auditorium at 3:30. And it's for teams of 2, no registration required. All of you can turn up with any person as your team. So see you all there.